Chapter 7. Racial and Ethnic Disparities in Healthcare. Over the course of its history, the United States has experienced dramatic improvements in overall health and life expectancy, largely as a result of initiatives in public health, health promotion, disease prevention, and chronic care management. Our ability to prevent, detect, and treat diseases in their early stages has allowed us to target and reduce rates of morbidity and mortality. Despite interventions that have improved the overall health of the majority of Americans, racial and ethnic minorities, Blacks, Hispanics, Latinos, Native Americans, Alaskan Natives, Asian, Pacific Islanders, have benefited less from these advances than whites and have suffered poorer health outcomes from many major diseases, including cardiovascular disease, cancer, and diabetes. These disparities highlight the importance of recognizing and addressing the social determinants of health, which contribute enormously to health outcomes. Research has revealed that minorities may receive less care and lower quality care than whites, even when confounders such as stage of presentation, comorbidities, and health insurance are controlled. These differences in quality are called racial and ethnic disparities in healthcare. These healthcare disparities have taken on greater importance with the significant transformation of the U.S. healthcare system and value-based purchasing. The shift toward creating financial incentives and disincentives to achieve quality goals makes focusing on those who receive lower quality care more important than ever before. This chapter will provide an overview of racial and ethnic disparities in health and healthcare, identify root causes, and provide key recommendations to address these disparities at both the clinical and health system levels. Nature and extent of disparities. Minority Americans have poorer health outcomes than whites from preventable and treatable conditions such as cardiovascular disease, diabetes, asthma, cancer, and HIV, AIDS, Fig. 7-1. Multiple factors contribute to these racial and ethnic disparities in health. First and foremost, social determinants, such as lower socioeconomic status, SES, e.g., lower income, less wealth, and lower educational attainment, inadequate and unsafe housing, and racism, are strongly linked to poor health outcomes. These factors disproportionately impact minority populations. In fact, SES has consistently been found to be one of the strongest predictors of health outcomes. While the mechanisms are complex, i.e., does poverty cause poor health, or does poor health cause poverty? It is clear that low SES populations experience disparities in health and that low SES is a major factor in racial, ethnic disparities. Racial, ethnic disparities are documented globally, although their assessment has centered more on the comparison of individuals by SES in other countries than in the United States. Similar to the U.S. pattern, low SES residents of other nations tend to have poorer health outcomes. It is noteworthy that results are mixed when the health status of nations is compared by SES. High SES nations such as the United States do not necessarily have health outcomes that correlate with their high expenditures for healthcare. For example, as of 2016, the United States ranks 27th in the world, just behind Serbia, on basic public health measures such as infant mortality. This ranking may be due in part to the correlation between wealth distribution and SES rather than just absolute SES. This area of active research is outside the scope of this chapter. Racism has more recently been shown to predict poorer health outcomes. The physiologic impact of the stress imposed by racism and poverty, including increased cortisol levels, can lead to chronic adverse effects on health. Lack of access to care also takes a significant toll. Uninsured individuals are less likely to have a regular source of care and are more likely to delay seeking care and to go without needed care. This limited access results in avoidable hospitalizations, emergency hospital care, and adverse health outcomes. In addition to racial and ethnic disparities in health, there are racial and ethnic disparities in the quality of care for persons with access to the healthcare system. For instance, disparities have been found in the treatment of pneumonia, Fig. 7-2, and congestive heart failure, with Blacks receiving less optimal care than whites when hospitalized for these conditions. Moreover, Blacks with end-stage renal disease are referred less often to the transplant list than are their white counterparts, Fig. 7-3. Disparities have been found, for example, in the use of cardiac diagnostic and therapeutic procedures, with Blacks being referred less often than whites for cardiac catheterization and bypass grafting, prescription of analgesia for pain control, with Blacks and Latinos receiving less pain medication than whites for long bone fractures and cancer, and surgical treatment of lung cancer, with blacks receiving less curative surgery than whites for non-small cell lung cancer. Again, many of these disparities have occurred even when variations in factors such as insurance status, income, age, comorbid conditions, and symptom expression are taken into account. However, one additional factor, disparities in the quality of care provided at the sites where minorities tend to receive care, has been shown to be an important contributor to overall disparities. Little progress has been made in addressing racial ethnic disparities in cardiovascular procedures and other advanced surgical procedures, whereas some progress has been made in eliminating disparities in primary care process measures. Data from the National Registry of Myocardial Infarction found evidence of continued disparities in guideline-based admission, procedural, and discharge therapy use from 1994 to 2006. Black patients were less likely than white patients to receive percutaneous coronary intervention, coronary artery bypass grafting, PCI, CABG, a disparity that has improved little since 1994. Further, compared with whites, black patients were less likely to receive lipid-lowering medications at discharge, with a gap that has widened since 1998, Figs 7-4. A 2009 study showed that blacks had worse post-myocardial infarction outcomes than whites, but that the difference could be explained by site of care and patient factors, such as socioeconomic status and comorbid conditions. The Centers for Disease Control and Prevention, CDC, analyzed national and state rates of total knee replacement, TKR, for Medicare enrollees for the period 2000 to 2006, with patients stratified by sex, age, and black or white race. TKR rates overall in the United States increased 58%, with similar increases among whites, 61%, and blacks, 56%. However, the TKR rate for blacks was 37% lower than the rate for whites in 2000 and 39% lower in 2006, i.e., the disparity not only did not improve but even worsened slightly, Figs 7-5. More recent data, up to 2010, show no apparent change in these figures. Data for enrollees in Medicare managed care plans provide evidence for a narrowing in racial disparities between 2006 and 2011 in several report card preventive care measures, such as mammography and glucose and cholesterol testing. However, racial disparities in more complex measures, such as glucose control in diabetic patients and cholesterol levels in patients after a heart attack, did not improve during that interval. The 2015 National Healthcare Quality and Disparities Report, released by the Agency for Healthcare Research and Quality, found few improvements in disparities for a wide range of quality measures between 2001 and 2013. In fact, for minority groups and poor people, disparities in the vast majority of core quality measures either stayed the same or got worse, including measures of effectiveness, patient safety, and timeliness of care. For example, for black versus white individuals, disparities in quality worsened for 102 measures and persisted for 116 measures out of 248 total measures, and disparities were eliminated in no measured area. This annual report is particularly important, given that most studies of disparities have not been repeated with the same methodology used to document possible trends. Some studies have tracked disparities using specific disease and treatment registries. For example, by 2008, the use of acute and discharge medications for myocardial infarction had largely been equalized among racial and ethnic groups. However, African American and Hispanic patients still experienced longer delays before reperfusion, with door-to-balloon times of less than 90 minutes for 83% of white patients as opposed to 75 and 76% of black and Hispanic patients, respectively. A recent review of disparities for kidney transplant recipients over 2 decades showed similar mixed findings, with trends for some measures improving while others worsened. Root causes of disparities. The National Academy of Medicine, formerly the Institute of Medicine, IOM, report Unequal Treatment, released in March 2002, remains the preeminent study of racial and ethnic disparities in healthcare in the United States. The IOM was charged with assessing the extent of racial ethnic differences in healthcare that are not otherwise attributable to known factors, such as access to care. To provide recommendations regarding interventions aimed at eliminating healthcare disparities, the IOM studied health system, provider, and patient factors. The study found the following: racial and ethnic disparities in healthcare exist and, because they are associated with worse health outcomes, are unacceptable. Racial and ethnic disparities in healthcare occur in the context of 1. Broader historic and contemporary social and economic inequality, and 2. Evidence of persistent racial and ethnic discrimination in many sectors of American life. Many sources, including health systems, healthcare providers, patients, and utilization managers, may contribute to racial and ethnic disparities in healthcare. Bias, stereotyping, prejudice, and clinical uncertainty on the part of healthcare providers may contribute to racial and ethnic disparities in healthcare. A small number of studies suggest that minority patients may be more likely to refuse treatments, yet these refusal rates are generally small and do not fully explain healthcare disparities. Unequal treatment went on to identify a set of root causes that included the following: health system factors. These include issues related to the complexity of the healthcare system, the difficulty that minority patients may have in navigating this complex system, and the lack of availability of interpreter services to assist patients with limited English proficiency. In addition, healthcare systems are generally ill-prepared to identify and address disparities. Provider-level factors. These include issues related to the healthcare provider, including stereotyping, the impact of race, ethnicity on clinical decision-making, and clinical uncertainty due to poor communication. Patient-level factors. These include patients' mistrust of the healthcare system leading to refusal of services, poor adherence to treatment, and delay in seeking care. A more detailed analysis of these root causes is presented below. Health system factors. Health system complexity. Even among persons who are insured and educated and who have a high degree of health literacy, navigating the U.S. healthcare system can be complicated and confusing. Some individuals may be at higher risk for receiving substandard care because of their difficulty navigating the system's complexities. These individuals may include those from cultures unfamiliar with the Western model of healthcare delivery, those with limited English proficiency, those with low health literacy, and those who are mistrustful of the healthcare system. These individuals may have difficulty knowing how and where to go for a referral to a specialist, how to prepare for a procedure such as a colonoscopy, or how to follow up on an abnormal test result such as a mammogram. Since people of color in the United States tend to be overrepresented among the groups listed above, the inherent complexity of navigating the healthcare system has been seen as a root cause for racial, ethnic disparities in healthcare. Other health system factors. Racial, ethnic disparities are due not only to differences in care provided within hospitals but also to where and from whom minorities receive their care, i.e., certain specific providers, geographic regions, or hospitals are lower performing on certain aspects of quality. For example, one study showed that 25% of hospitals cared for 90% of Black Medicare patients in the United States and that these hospitals tended to have lower performance scores on certain quality measures than other hospitals. That said, health systems generally are not well prepared to measure, report, and intervene to reduce disparities in care. Few hospitals or health plans stratify their quality data by race, ethnicity, or language to measure disparities, and even fewer use data of this type to develop disparity-targeted interventions. Similarly, despite regulations concerning the need for professional interpreters, research demonstrates that many healthcare organizations and providers fail to routinely provide this service for patients with limited English proficiency. Despite the link between limited English proficiency and healthcare quality and safety, few providers or institutions monitor performance for patients in these areas. Provider-level factors. Provider-patient communication. Significant evidence highlights the impact of sociocultural factors, race, ethnicity, and limited English proficiency on health and clinical care. Healthcare professionals frequently care for diverse populations with varied perspectives, values, beliefs, and behaviors regarding health and well-being. The differences include variations in the recognition of symptoms, thresholds for seeking care, comprehension of management strategies, expectations of care, including preferences for or against diagnostic and therapeutic procedures, and adherence to preventive measures and medications. In addition, sociocultural differences between patient and provider influence communication and clinical decision-making and are especially pertinent. Evidence clearly links provider-patient communication to improved patient satisfaction, regimen adherence, and better health outcomes, Fig. 7-6. Thus, when sociocultural differences between patient and provider are not appreciated, explored, understood, or communicated effectively during the medical encounter, patient dissatisfaction, poor adherence, poorer health outcomes, and racial, ethnic disparities in care may result. A survey of 6,722 Americans is greater than or equal to 18 years of age is particularly relevant to this important link between provider-patient communication and health outcomes. Whites, African Americans, Hispanics, Latinos, and Asian Americans who had made a medical visit in the past 2 years were asked whether they had trouble understanding their doctors, whether they felt the doctors did not listen, and whether they had medical questions they were afraid to ask. The survey found that 19% of all patients experienced one or more of these problems, yet whites experienced them 16% of the time as opposed to 23% of the time for African Americans, 33% for Hispanics, Latinos, and 27% for Asian Americans, Fig 7-7. In addition, in the setting of even a minimal language barrier, provider-patient communication without an interpreter is recognized as a major challenge to effective healthcare delivery. These communication barriers for patients with limited English proficiency lead to frequent misunderstanding of diagnosis, treatment, and follow-up plans, inappropriate use of medications, lack of informed consent for surgical procedures, high rates of adverse events with more serious clinical consequences, and a lower quality healthcare experience than is provided to patients who speak fluent English. Physicians who have access to trained interpreters report a significantly higher quality of patient-physician communication than physicians who use other methods. Communication issues related to discordant language disproportionately affect minorities and likely contribute to racial, ethnic disparities in healthcare. Clinical decision-making. Theory and research suggest that variations in clinical decision-making may contribute to racial and ethnic disparities in healthcare. Two factors are central to this process: clinical uncertainty and stereotyping. First, a doctor's decision-making process is nested in clinical uncertainty. Doctors depend on inferences about severity based on what they understand about illness and the information obtained from the patient. A doctor caring for a patient whose symptoms he or she has difficulty understanding and whose signals, the set of clues and indications that physicians rely on to make clinical decisions, are hard to read may make a decision different from the one that would be made for another patient who presents with exactly the same clinical condition. Given that the expression of symptoms may differ among cultural and racial groups, doctors, the overwhelming majority of whom are white, may understand symptoms best when expressed by patients of their own racial, ethnic groups. The consequence is that white patients may be treated differently from minority patients. Differences in clinical decisions can arise from this mechanism even when the doctor has the same regard for each patient, i.e., is not prejudiced. Second, the literature on social cognitive theory highlights how natural tendencies to stereotype may influence clinical decision-making. Stereotyping can be defined as the way in which people use social categories, e.g., race, gender, age, in acquiring, processing, and recalling information about others. Faced with enormous information loads and the need to make many decisions, people often subconsciously simplify the decision-making process and lessen cognitive effort by using categories, or stereotypes, that bundle information into groups or types that can be processed more quickly. Although functional, stereotyping can be systematically biased, as people are automatically classified into social categories based on dimensions such as race, gender, and age. Many people may not be aware of their attitudes, may not consciously endorse specific stereotypes, and paradoxically may consider themselves egalitarian and not prejudiced. Stereotypes may be strongly influenced by the messages presented consciously and unconsciously in society. For instance, if the media and our social, professional contexts tend to present images of minorities as being less educated, more violent, and non-adherent to healthcare recommendations, these impressions may generate stereotypes that unnaturally and unjustly impact clinical decision-making. As signs of racism, classism, gender bias, and ageism are experienced, consciously or unconsciously, in our society, stereotypes may be created that impact the way doctors manage patients from these groups. On the basis of training or practice location, doctors may develop certain perceptions about race, ethnicity, culture, and class that may evolve into stereotypes. For example, many medical students and residents are trained, and minorities cared for, in academic health centers or public hospitals located in socioeconomically disadvantaged areas. As a result, doctors may begin to equate certain races and ethnicities with specific health beliefs and behaviors, e.g., these patients engage in risky behaviors, those patients tend to be non-compliant, that are more associated with the social environment, e.g., poverty, than with a patient's racial, ethnic background or cultural traditions. This conditioning phenomenon may also be operative if doctors are faced with certain racial, ethnic patient groups who frequently do not choose aggressive forms of diagnostic or therapeutic intervention. The result over time may be that doctors begin to believe that these patients do not like invasive procedures, thus they may not offer these procedures as options. A wide range of studies have documented the potential for provider biases to contribute to racial, ethnic disparities in healthcare. For example, one study measured physicians' unconscious, or implicit, biases and showed that these were related to differences in decisions to provide thrombolysis for a hypothetical black or white patient with a myocardial infarction. It is important to differentiate stereotyping from prejudice and discrimination. Prejudice is a conscious prejudgment of individuals that may lead to disparate treatment, and discrimination is conscious and intentional disparate treatment. All individuals stereotype subconsciously, yet, if left unquestioned, these subconscious assumptions may lead to lower quality care for certain groups because of differences in clinical decision making or differences in communication and patient-centeredness. For example, one study tested physicians' unconscious racial, ethnic biases and showed that patients perceived more biased physicians as being less patient-centered in their communication. What is particularly salient is that stereotypes tend to be activated most in environments where the individual is stressed, multitasking, and under time pressure, the hallmarks of the clinical encounter. In fact, in a survey of close to 16,000 physicians, 42% admitted that bias, including by race and ethnicity, impacted their clinical decision-making. Interestingly, emergency medicine physicians, who worked in environments of stress, time pressure, risk, and where they are multitasking, topped the list by discipline at 62%. Patient-level factors. Lack of trust has become a major concern for many healthcare institutions today. For example, an IOM report, To Err as Human, Building a Safer Health System, documented alarming rates of medical errors that made patients feel vulnerable and less trustful of the U.S. healthcare system. The increased media and academic attention to problems related to quality of care, and of disparities themselves, has clearly diminished trust in doctors and nurses. Trust is a crucial element in the therapeutic alliance between patient and healthcare provider. It facilitates open communication and is directly correlated with adherence to the physician's recommendations and the patient's satisfaction. In other words, patients who mistrust their healthcare providers are less satisfied with the care they receive, and mistrust of the healthcare system greatly affects patients' use of services. Mistrust can also result in inconsistent care, doctor shopping, self-medication, and an increased demand by patients for referrals and diagnostic tests. On the basis of historic factors such as discrimination, segregation, and medical experimentation, blacks may be especially mistrustful of providers. The exploitation of blacks by the U.S. Public Health Service during the Tuskegee syphilis study from 1932 to 1972 left a legacy of mistrust that persists even today among this population. Other populations, including Native Americans, Alaskan Natives, Hispanics, Latinos, and Asian Americans, also harbor significant mistrust of the healthcare system. A national survey conducted by the Kaiser Family Foundation found that there is significant mistrust for the healthcare system among minority populations. Of the 3,884 individuals surveyed, 36% of Hispanics and 35% of blacks, compared to 15% of whites, felt they were treated unfairly in the healthcare system in the past based on their race and ethnicity. Perhaps even more alarming, 65% of blacks and 58% of Hispanics, compared to 22% of whites, were afraid of being treated unfairly in the future based on their race, ethnicity, Fig. 7-8. This mistrust may contribute to wariness in accepting or following recommendations, undergoing invasive procedures, or participating in clinical research, and these choices, in turn, may lead to misunderstanding and the perpetuation of stereotypes among health professionals. Key recommendations to address racial, ethnic disparities in healthcare. The publication Unequal Treatment provides a series of recommendations to address racial and ethnic disparities in healthcare, focusing on a broad set of stakeholders. These recommendations include health system interventions, provider interventions, patient interventions, and general recommendations, which are described in more detail below. Health system interventions. Collection and reporting of data on healthcare access and use, by patients' race, ethnicity. Unequal Treatment found that the appropriate systems to track and monitor racial and ethnic disparities in healthcare are lacking and that less is known about the disparities affecting minority groups other than African Americans, Hispanics, Asian Americans, Pacific Islanders, Native Americans, and Alaskan Natives. For instance, only in the mid-1980s did the Medicare database begin to collect data on patient groups outside the standard categories of white, black, and other. Federal, private, and state-supported data collection efforts are scattered and unsystematic, and many healthcare systems and hospitals still do not collect data on the race, ethnicity, or primary language of enrollees or patients. A survey by the Institute for Diversity in Health Management and the Health Research and Educational Trust in 2015 found that 98% of 1083 U.S. hospitals collected information on race, 95% collected data on ethnicity, and 94% collected data on primary language. However, only 45% collected data on race, 40% collected data on ethnicity, and 38% collected data on primary language to benchmark gaps in care. A survey by America's Health Insurance Plans Foundation in 2008 and 2010 showed that the proportion of enrollees in plans that collected race, ethnicity data of some type increased from 75 to 79%. However, the total percentage of plan enrollees whose race, ethnicity, and language are recorded is still much lower than these figures. Encouragement of the use of evidence-based guidelines and quality improvement. Unequal treatment highlights the subjectivity of clinical decision-making as a potential cause of racial and ethnic disparities in healthcare by describing how clinicians, despite the existence of well-delineated practice guidelines, may offer, consciously or unconsciously, different diagnostic and therapeutic options to different patients on the basis of their race or ethnicity. Therefore, the widespread adoption and implementation of evidence-based guidelines is a key recommendation in eliminating disparities. For instance, evidence-based guidelines are now available for the management of diabetes, HIV, AIDS, cardiovascular diseases, cancer screening and management, and asthma, all areas where significant disparities exist. As part of ongoing quality improvement efforts, particular attention should be paid to the implementation of evidence-based guidelines for all patients, regardless of their race and ethnicity. Support for the use of language interpretation services in the clinical setting. As described previously, a lack of efficient and effective interpreter services in a healthcare system can lead to patient dissatisfaction, to poor comprehension and adherence, and thus to ineffective, lower quality care for patients with limited English proficiency. Unequal treatment's recommendation to support the use of interpretation services has clear implications for delivery of quality healthcare by improving doctors' ability to communicate effectively with these patients. Increases in the proportion of underrepresented minorities in the healthcare workforce. Data for 2014 from the Association of American Medical Colleges indicate that, of the 72.4% of U.S. physicians whose race and ethnicity are known, Hispanics make up 4.1%, Blacks 4.1%, and Native American and Alaskan Natives 0.4%. Furthermore, U.S. national data show that minorities, excluding Asians, compose just 7.1% of full-time medical school faculty. In addition, minority faculty in 2007 were more likely to be at or below the rank of assistant professor, while whites composed the highest proportion of full professors. Similarly, a 2012 study found that both Hispanic and Black faculty were promoted at lower rates than their white counterparts. Despite representing approximately 26% of the U.S. population, a number projected to almost double by 2050, minority students are still underrepresented in medical schools. In 2016, matriculates to U.S. medical schools were 6.1% Latino, 6.6% African American, 0.1% Native Hawaiian or other Pacific Islander, and 0.3% Native American or Alaskan Native. These percentages have decreased or remained the same since 2007. It will be difficult to develop a diverse healthcare workforce that can meet the needs of an increasingly diverse population without dramatic changes in the racial and ethnic composition of medical student bodies. Provider interventions. Integration of cross-cultural education into the training of all healthcare professionals. The goal of cross-cultural education is to improve providers' ability to understand, communicate with, and care for patients from diverse backgrounds. Such education focuses on enhancing awareness of sociocultural influences on health beliefs and behaviors and on building skills to facilitate understanding and management of these factors in the medical encounter. Cross-cultural education includes curricula on healthcare disparities, use of interpreters, and effective communication and negotiation across cultures. These curricula can be incorporated into health professions training in medical schools, residency programs, nursing schools, and other health professions programs, and can be offered as a component of continuing education. Despite the importance of this area of education and the attention it has attracted from medical education accreditation bodies, a national survey of senior resident physicians by Weissman and colleagues found that up to 28% felt unprepared to deal with cross-cultural issues, including caring for patients who have religious beliefs that may affect treatment, patients who use complementary medicine, patients who have health beliefs at odds with Western medicine, patients who mistrust the healthcare system, and new immigrants. In a study at one medical school, 70% of fourth-year students felt inadequately prepared to care for patients with limited English proficiency. Efforts to incorporate cross-cultural education into medical education will contribute to improving communication and to providing a better quality of care for all patients. Incorporation of teaching on the impact of race, ethnicity, and culture on clinical decision-making. Unequal treatment and more recent studies found that stereotyping by healthcare providers can lead to disparate treatment based on a patient's race or ethnicity. The Liaison Committee on Medical Education, which accredits medical schools, issued a directive that medical education should include instruction on how a patient's race, ethnicity, and culture might unconsciously impact communication and clinical decision-making. Patient interventions. Difficulty navigating the healthcare system and obtaining access to care can be a hindrance to all populations, particularly to minorities. Similarly, lack of empowerment or involvement in the medical encounter by minorities can be a barrier to care. Patients need to be educated on how to navigate the healthcare system and how best to access care. Interventions should be used to increase patients' participation in treatment decisions. General recommendations. Increase awareness of racial, ethnic disparities in healthcare. Efforts to raise awareness of racial, ethnic healthcare disparities have done little for the general public but have been fairly successful among physicians, according to a Kaiser Family Foundation report. In 2006, nearly 6 in 10 people surveyed believed that blacks received the same quality of care as whites, and 5 in 10 believed that Latinos received the same quality of care as whites. These estimates are similar to findings in a 1999 survey. Despite this lack of awareness, most people believed that all Americans deserve quality care, regardless of their background. In contrast, the level of awareness among physicians has risen sharply. In 2002, the majority, 69%, of physicians said that the healthcare system, rarely or never, treated people unfairly on the basis of their racial, ethnic background. In 2005, less than one quarter, 24%, of physicians disagreed with the statement that minority patients generally receive lower quality care than white patients. More recently, a survey by WedMD showed that 42% of 16,000 physicians admitted that their own personal biases impact their clinical decision-making, including on characteristics such as race and ethnicity. Increasing awareness of racial and ethnic health disparities, and their root causes, among healthcare professionals and the public is an important first step in addressing these disparities. The ultimate goals are to generate discourse and to mobilize action to address disparities at multiple levels, including health policymakers, health systems, and the community. Conduct further research to identify sources of disparities and promising interventions. While the literature that formed the basis for the findings reported and recommendations made in unequal treatment provided significant evidence for racial and ethnic disparities, additional research is needed in several areas. First, most of the literature on disparities focuses on black versus white differences. Much less is known about the experiences of other minority groups. Improving the ability to collect racial and ethnic patient data should facilitate this process. However, in instances where the necessary systems are not yet in place, racial and ethnic patient data may be collected prospectively in the setting of clinical or health services research to more fully elucidate disparities for other populations. Second, much of the literature on disparities to date has focused on defining areas in which these disparities exist, but less has been done to identify the multiple factors that contribute to the disparities or to test interventions to address these factors. There is clearly a need for research that identifies promising practices and solutions to disparities. Implications for clinical practice. Individual healthcare providers can do several things in the clinical encounter to address racial and ethnic disparities in healthcare. Be aware that disparities exist. Increasing awareness of racial and ethnic disparities among healthcare professionals is an important first step in addressing disparities in healthcare. Only with greater awareness can care providers be attuned to their behavior in clinical practice and thus monitor that behavior and ensure that all patients receive the highest quality of care, regardless of race, ethnicity, or culture. Practice culturally competent care. Previous efforts have been made to teach clinicians about the attitudes, values, beliefs, and behaviors of certain cultural groups, the key practice, do's and don'ts, in caring for the Hispanic patient, or the Asian patient, for example. In certain situations, learning about a particular local community or cultural group, with a goal of following the principles of community-oriented primary care, can be helpful. When broadly and uncritically applied, however, This approach can actually lead to stereotyping and oversimplification of culture, without respect for its complexity. Cultural competence has thus evolved from merely learning information and making assumptions about patients on the basis of their backgrounds to focusing on the development of skills that follow the principles of patient-centered care. Patient-centeredness encompasses the qualities of compassion, empathy, and responsiveness to the needs, values, and expressed preferences of the individual patient. Cultural competence aims to take things a step further by expanding the repertoire of knowledge and skills classically defined as patient-centered, to include those that are especially useful in cross-cultural interactions, and that, in fact, are vital in all clinical encounters. This repertoire includes effectively using interpreter services, eliciting the patient's understanding of his or her condition, assessing decision-making preferences and the role of family, determining the patient's views about biomedicine versus complementary and alternative medicine, recognizing sexual and gender issues, and building trust. For example, while it is important to understand all patients' beliefs about health, it may be particularly crucial to understand the health beliefs of patients who come from a different culture or have a different healthcare experience. With the individual patient as teacher, the physician can adjust his or her practice style to meet the patient's specific needs. Avoid stereotyping. Several strategies can allow healthcare providers to counteract, both systemically and individually, the normal tendency to stereotype. For example, when racially, ethnically, culturally, socially diverse teams in which each member is given equal power are assembled and are tasked to achieve a common goal, a sense of camaraderie develops and prevents the development of stereotypes based on race, ethnicity, gender, culture, or class. Thus, healthcare providers should aim to gain experiences working with and learning from a diverse set of colleagues. In addition, simply being aware of the operation of social cognitive factors allows providers to actively check up on or monitor their behavior. Physicians can constantly reevaluate to ensure that they are offering the same things, in the same ways, to all patients. Understanding one's own susceptibility to stereotyping, and how disparities may result, is essential in providing equitable, high-quality care to all patients. Work to build trust. Patients' mistrust of the healthcare system and of healthcare providers impacts multiple facets of the medical encounter, with effects ranging from decreased patient satisfaction to delayed care. Although the historic legacy of discrimination can never be erased, several steps can be taken to build trust with patients and to address disparities. First, providers must be aware that mistrust exists and is more prevalent among minority populations, given the history of discrimination in the United States and other countries. Second, providers must reassure patients that they come first, that everything possible will be done to ensure that they always get the best care available, and that their caregivers will serve as their advocates. Third, interpersonal skills and communication techniques that demonstrate honesty, openness, compassion, and respect on the part of the healthcare provider are essential tools in dismantling mistrust. Finally, patients indicate that trust is built when there is shared, participatory decision-making and the provider makes a concerted effort to understand the patient's background. When the doctor-patient relationship is reframed as one of solidarity, the patient's sense of vulnerability can be transformed into one of trust. The successful elimination of disparities requires trust-building interventions and strengthening of this relationship. Conclusion. The issue of racial and ethnic disparities in healthcare has gained national prominence, both with the release of the IOM report Unequal Treatment and with more recent articles that have confirmed their persistence and explored their root causes. Furthermore, another influential IOM report, Crossing the Quality Chasm, has highlighted the importance of equity, i.e., no variations in quality of care due to personal characteristics, including race and ethnicity, as a central principle of quality. Current efforts in healthcare reform and transformation, including a greater focus on value, high-quality care and cost control, will sharpen the nation's focus on the care of populations who experience low-quality, costly care. Addressing disparities will become a major focus, and there will be many obvious opportunities for interventions to eliminate them. Greater attention to addressing the root causes of disparities will improve the care provided to all patients, not just those who belong to racial and ethnic minorities.